Let's move on to Dr. Hiremath, who's one of our neurosurgeons, who's going to talk about some of the procedural approaches. I think a big takeaway from what you just heard is that there are lots of therapeutic options to kind of smooth out and patch and shave your data to keep you moving well. Okay?
Good morning, everybody. My talk is on surgery for Parkinson's disease. We started a program here close to 3 years ago, and we've hit a couple bumps in the road just from COVID just shutting us down, but we have a good momentum going now, and I'd like to just sort of introduce the concept of surgery for Parkinson's disease, and there's also a short video with my talk. So first off, we have people asking about deep brain stimulation surgery, which is the topic of this talk, and the first thing I'd like to point out is that it's not a cure for Parkinson's disease. As you may know, there is really no cure for Parkinson's disease. But what it is a brain, you can think of it as a brain pacemaker. There are some abnormal circuits as a result of the loss of dopamine that results in most of the motor symptoms of Parkinson's disease. And DBS is an effective treatment for the motor symptoms of Parkinson's disease. The people who are candidates for DBS are the people for whom dopamine has worked. And in general, if dopamine hasn't worked for you, DBS probably won't help, except in the case of people who have Parkinson's disease where the tremor is the predominant motor symptom. Okay? It's usually also not effective most of the time for people who have atypical Parkinson's disease. What we're talking about today is idiopathic Parkinson's disease, but there are some Parkinsonian syndromes which may take the neurologist a few years to sort of understand that somebody's having atypical Parkinson's and not what we call standard or idiopathic Parkinson's disease. And so that's why we wait about 4 years after the diagnosis of Parkinson's before DBS is offered. In addition, the first few years after the disease has been diagnosed is usually when people have a really good response to dopamine treatment. And so it's not a situation where we're trying to move somebody forward through surgery in the first few years after surgery. So for a few different reasons, we usually wait several years before we talk about surgery. So what are the goals? What are we trying to establish when we put somebody through this brain surgery? So the goal that I explain to my patients in the office is we want to get you to your best on time. When you feel nice and loose and when you're on, that's how we want you to stay with DBS, more or less, with minimal on-off fluctuation. But the most important thing is that people who have on time, as Dr. Patel explained, over the course of the latter part of the disease, they develop troublesome dyskinesia. So they're off, they're really stiff, or they're on with dyskinesias that are disabling. So we want to get somebody with DBS to their best on time without dyskinesia. And we want to improve the rigidity, the slowness in movement, the tremor. Those symptoms all have a very good chance of improving with DBS surgery. We may or may not be able to reduce levodopa dosing following successful DBS programming, but it sort of depends on where we implant the electrode. And I like the iceberg analogy that Dr. Patel put up. I'm going to steal a few things from his slides as I'm moving through it today. So, but yeah, it doesn't improve the non-motor symptoms. People have often what we call fog or freezing of gait, and it may not improve the freezing of gait that's associated with Parkinson's disease. We think that in general, with DBS, people have about 10 to 15 years of improvement before the disease continues to progress. As you know, Parkinson's is a degenerative disease, and it does progress. So how do we evaluate whether somebody is a good candidate for DBS surgery? So the first thing is, we wait about 3 to 4 years so that we understand that somebody truly has Parkinson's disease, because it takes us that amount of time to make that diagnosis in most cases. And then we want to test somebody with something called on-off testing. Is that when we hold your dopamine and we test how you're moving about with the motor function with the scale called the UPDRS scale. And we need a minimum of 30% change in the scoring between when you're on and off. And so if that's the case, it makes you a good candidate for DBS, but that's not enough. Usually we have to consider other issues, whether there are, signs of dementia, if you're medically fit enough to have the surgery. We have a detailed evaluation with speech therapy, and the neuropsychologist also sees you. So after all of that information has been gathered, we sit together at a conference, usually once a month, and we discuss patients that are possibly candidates for DBS surgery. If somebody's we feel is a good candidate, then I see them in the office. We talk in detail about the surgery, and then we just take them through the surgical scheduling process. So this is a little bit of a crash course in neuroscience here. Suffice it to say that when somebody exhibits the symptoms of Parkinson's disease, that means that 80% of the cells in this part of the brain called the substantia nigra have already died, and they're not producing enough dopamine. The oil that Dr. Patel mentioned, so that's basically running out. So in general, there's sort of two systems. I don't know which is the pointer here. Is it the red button? Okay, perfect. Got it. So, I'm sorry, people online can't see this. Apologize, but basically, we have this in a normal situation. We have dopamine being produced. We want this direct pathway to be functioning because it helps to facilitate a movement. If I'm going to reach for my coffee cup, the movement is nice and smooth, and I can reach the coffee cup and pick it up without spilling it. So we rely on the direct pathway to make sure that that takes place. We want the indirect pathway to be, in general, inhibited. They both work in a sort of a smooth balance in the normal situation. But when we don't have enough dopamine, we have overactivation of the indirect pathway and sort of underactivation of the direct pathway. And what that causes the cardinal features of Parkinson's disease, the stiffness, the slowness. So the key parts of your brain, the nuclei that are sort of what we call targets to try to correct some of this imbalance in the pathways, those two nuclei are the subthalamic nucleus and the globus pallidus. And that's usually where we implant somebody who has Parkinson's disease. So how does it work? And the short answer is that we actually don't know how it works. We think that it creates a temporary lesion in these structures, but that doesn't exactly explain the full mechanism of deep brain stimulation. But just like a cardiac pacemaker, which negates some of the abnormal rhythms of the heart, we think that DBS works similarly, and it may affect electrical, chemical, and network properties, and it may reduce sort of abnormal rhythms in the brain. The three main things, and this is sort of the most important, the three things that we talk about in making sure a DBS operation is successful is choosing the right patient, making sure we hit the right target in surgery. We have to be highly accurate, that is less than 1.5 to 2 millimeters off the target, and having somebody who successfully is able to program the electrode. So if we don't have any of those three pieces, the DBS is not going to work as well for you. So we think that, and this is sort of, the newer information, is that there's a neurologist in Oxford named Peter Brown who found out that people who have Parkinson's have this abnormal rhythm. We can use this as a biomarker. It's called a beta band. And that when they have the worst symptoms of Parkinson's disease, when they're off, they have a higher chance of exhibiting this, what they can call a beta band. And so when we give somebody dopamine, the beta band is suppressed. So we can use that as a potential biomarker. This is sort of the future of DBS, is that the system can sense when there's a beta band and deliver the current. So this is a little bit of a taste of what are things to come. So DBS history, how do we find out about DBS? How was this developed? Well, we knew that in the 1960s, when we created a lesion in those parts of the brain called the globus pallidus or the subthalamic nucleus, that would improve the symptoms of Parkinson's disease. And so we already knew the pathways involved, But in the 60s, dopamine came about. And so dopamine improved the symptoms of Parkinson's without putting somebody through brain surgery. And so surgery fell out of favor. Over the course of the next 10 to 20 years, we found that, okay, dopamine, it's not a cure. And over the course of time, we have a lot of on-off fluctuations. There's a lot of side effects. And so there was this resurgence of interest in surgery. You can think of the first person to have performed DBS operation was Dr. Bektareva. She was a neurosurgeon in this former Soviet Union, and she actually had the idea of implanting an electrode and running a current, sort of chronic stimulation for these structures. But really, the man who, what we think of as modern-day DBS, is sort of the pioneer of modern-day DBS, is Dr. Benabit, and I had the fortune of meeting him in Scotland at one of the conferences. So he's basically the one in Grenoble, France, who developed what we think of as modern-day DBS. And he published some of the first series in the late 80s and late 90s about the success of DBS. Other groups followed in North America, especially the group in Toronto. So this is sort of the basic setup of a DBS system. There is an electrode placed in the target in the brain, one of three, basically subthalamic nucleus, the globus pallidus, or the thalamus. And that lead, this is sort of a magnified look at that lead. This is the latest version of the lead that we use here, the Medtronic lead. Now we are able to have a directional lead. We can shoot the current off in a different direction to focus the energy in the part of the brain where we want it and away from more eloquent parts of the brain, which may give people side effects. And this is sort of the newest version of the battery that we use. It has this ability, what's called closed loop, which is it has the ability to identify that beta band and deliver the current appropriately. Any questions? I know there's a lot of technical information. Okay. So in the United States, DBS was approved first for the tremor associated with Parkinson's disease in 1997. And then the FDA approved subthalamic nucleus DBS for advanced Parkinson's disease. And then the globus pallidus was a second target. And then usually we're waiting about 6-7 years before somebody was offered DBS. And then based on further literature, the FDA approved earlier DBS for Parkinson's disease. Now we start to talk about DBS surgery about 3 or 4 years. So this is one of the landmark studies that shows the effectiveness of DBS compared with medical treatment. It's very easy to tell, a lot of surgery that I do, we don't have sort of the best literature. We sort of go on, okay, well, we think this helps this person, let's do this operation. Well, it's very easy with DBS. I can turn off the DBS, I can show you that the surgery is working. So, when we look at people who were treated with just medicine, and we follow them out for 6 months versus people who were treated with DBS. So this is sort of the change that we see, and this is sort of hours on the day on the y-axis, and the people's baseline, and at 6 months. You could see in yellow the number of hours that people were mobile without dyskinesias more than doubled. So they initially had 3 hours of mobility without dyskinesia, and that more than doubled to 7.6 hours. And the number of hours that they were immobile fell significantly from 6 hours to 2 hours. So this was one of the earlier studies. And of course, with the technology, we've sort of had maybe even better improvement in functional outcome. So just illustrating to you the targets for the GPI. GPI you can think of as sort of like an onion peel, sort of the deepest part of the onion peel. It's one of the targets for deep brain stimulation. This is a subthalamic nucleus, which is like an almond. It's about 8 millimeters in one dimension and about 5-6 millimeters in another dimension. And we have to hit 1/2 of the top part of the nucleus, so we have to be highly accurate. But it's a very effective target for DBS. So when we were sort of performing traditional DBS surgery, we had, how many minutes do I have? Am I running over?
Yeah, but that's okay.
Okay, sorry.
That's why I'm standing.
Okay.
This is the light.
It's just like a.
Light, so I'm
Gotcha. Okay.
standing
All right.
ominously on the side.
All right. I'll move through. Sorry.
You're okay. It's informative.
So awake DBS is sort of the way the standard way, traditional way of doing DBS from many, many years ago, because we couldn't really see these nuclei on even the best imaging that we had. So we had coordinate systems in the brain, and we would sort of use the coordinate systems to sort of make a general target trajectory. And then we would have somebody awake and test them with something called microelectrode recording, because each nucleus has a traditional sort of signature of how the nuclei, the cells sound. And we can stimulate the person and see if their symptoms get better and make sure that we're not giving them any side effects. We still do this. And this is sort of the gold standard of implanting an electrode. It's real time, and we have spatial as well as electrophysiological confirmation. But of course, having brain surgery with somebody awake, it's not something that people line up and try to volunteer for, right? So we try to make, as time goes on, the goal is that we make the surgery more acceptable, more palatable to people who want to have the surgery. And so I think the biggest development is that we have had improvement in imaging to the point where we can implant the nucleus without having somebody awake. And we're already doing this at our center. I think gradually as our center develops and we sort of grow our program, we're having more and more people have the surgery asleep. So we can see the target, we can hit the target, and we don't have to have somebody awake. So it has, of course, the potential to vastly increase the number of DBS currently being performed, which is, as you know, it's an underutilized surgery in this country. So the sort of the landmark paper that came out about 4 or 5 years ago was from the Oregon Health Sciences University. Dr. Burchell, who's sort of a pioneer in DBS, he showed that it has just as good targeting accuracy and maybe better clinical outcomes than people who have who have awake DBS. I have a short video of. Do we have time for that?
Yeah.
Okay. This is a paper I wrote for Neurology India about our technique. We have a fully robotic DBS technique here, and we could just show you that 7-minute video. Can we switch to that, please?
This video illustrates the surgical technique used to place deep brain stimulation electrodes using the Neuromate robot and the ORM intraoperative imaging system. The patient's consent has been taken and due precautions have been taken to anonymize the patient's identity. The following is purely a teaching video and is not meant to promote any doctor or hospital. This is a 59-year-old woman with tremor-predominant Parkinson's disease for 5 years duration. The diagnosis of PD was confirmed with a DAT scan. Imaging.
Yeah, there we go.
The luminant reference must be adequately visualized on both AP.
So this is an intraoperative CT scanner, and this person is in a frame.
Spin is performed.
And it's attached to the robot base. The head is attached via the frame to the robot base. This is a scan that we get in the surgery. We fuse it with the MRI. And we check the robot's accuracy. We have the robot arm move, which you'll see here. And we place a staple on the scalp, and we tell the robot go and point to the staple, and if it does, that means it's highly accurate.
The laser tool holder, now attached to the robot arm, is driven to the target. As can be seen here, the laser is pointing to the medial edge of the staple, confirming excellent accuracy. The robot is now driven
1 minute.
using the laser to the entry points on the scalp. Entry points are then marked with a permanent marker. Beginning at 10 millimeter bushing is inserted into the robot tool holder. This bushing will accommodate a 3.2 millimeter drill bit. The robot arm is.
So here we're placing the microelectrode that listens in on the cells.
Microelectrode recordings. The objective is to confirm.
That's Dr.
accurate
Hardwick.
targeting
She's testing
of
the patient in
dorsolateral
surgery to
sensory
make sure we hit the
portion
target.
of the
We have a good
STN
response.
with good somatic. This part of the video shows portions of recording of both the right as well as the left STN. As can be seen here, the patient had improvement in preoperative symptoms. This is felt to be a combination of a microlesion effect as well as test stimulation. Satisfied with MER
So
recordings
then we
along
placed
the
the
initial
main
track,
brain electrode.
a 3389 Medtronic DBS microelectrode was placed at target using the star drive lead holder. Monopolar review of each of the 4 contacts was performed to ensure good therapy without side effects. A piece of tape is placed on the O-arm screen and the tip of the macroelectrode is
Move
marked on the
forward.
tape
Probably
prior
like
to
a minute.
manipulation of the macroelectrode and from the skull. Multiple
Oh, there's only a
spot
minute.
X-rays are obtained using
Okay,
the
I think
O-arm
we're
to
good.
ensure the
Keep
macroelectrode
going.
is not inadvertently.
So the yellow line is where we
Prior
want it
to
to be, and the
incision
white is
closure
the actual
and-
electrode. Because so as you can see, we're like exactly where we need to be. So the robot helps us be highly accurate.
Mirroring the intended trajectory and antibiotic impregnated.
So this is, I think, the
Initial
sweetest part of the
programming
video.
of her 4-week
So
postoperative visit. At her
this is
6-week
we have this
postoperative
patient
visit,
with her
as
stim
can be
off,
seen here,
and she's
she has
shaking.
a significant resting tremor with therapy turned off.
And I should turn it on.
And she enjoys substantial improvement in tremor with DBS therapy turned on.
She's like, it's gone. It's gone. So yeah, it gets us every time too. I can't believe it either. So so. Thanks. Sorry, I ran over.
It's good run over. Do you have anyone have any questions? We're not in a rush. It's phenomenal technology, and Dr. Hiremath is the surgeon that brought it to us, and now we have another surgeon who's doing it. And
He just joined us about 6 to 7 months ago, so he's helping to grow the program as well. So we're very fortunate.
so really super helpful, and thank you so much. That was really
pleasure.
informative.